Hello, my name is Dr. Amy Pollack. I practice cardiovascular medicine at the Mayo Clinic in Florida, and I'm really delighted to be with you today to talk about best practices to address disparities with a focus on prevention in the clinic. I have no disclosures, and our learning objective is this, really to explore those best practices to aim to address health disparities related to prevention in the clinic for our patients who either have PAD or who are at risk for having PAD. And I'm really excited that there is a whole complement of quick tip videos. And so you can learn about prevalence of PAD, detection of PAD, pre and post interventional care, and then outcomes, all with a focus on addressing health disparities in these additional quick tip videos. So this is a really focused topic. So I'm going to start with a little bit about understanding health disparities and health literacy, why this is so critical to our care of patients, and then spend the bulk of our time talking about prevention strategies for PAD in the clinic, and then a little bit about next steps. So we'll just start with a focus on health disparities and what is meant by this term. We hear it often, and hopefully in the future we'll be discussing this even more so because it's so important to the care of our patients with cardiovascular disease, primary care, and certainly our patients with PAD. So health disparities are preventable differences. And this is really key. We have an opportunity, a call to action to address these disparities because they are preventable. And they are the preventable differences in the indicators of health of different population groups, often defined by race, ethnicity, sex, education level, socioeconomic status, and geographic location. And this quote from Martin Luther King Jr. just really, I think, speaks to me and I think to everyone that of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. So we have a call to action, and I'm looking forward to talking about what we can do in the clinic-based practice to answer this call to action. So if we look at social determinants of health, this is what goes into the health disparities. It's, those social determinants involve education, access to education, quality of education, the access and quality of healthcare that somebody is eligible for or is able to receive, economic stability, the social and community context where they live, and then the neighborhood and the built environment. Do they have access to safe walking paths? Is there environmental pollution? Is it safe to go outside and walk to exercise? Food deserts. So much of the social determinants of health really play an important role for an increased risk of PAD, or peripheral artery disease. Health literacy, this is that degree to which an individual can access, process, and comprehend the basic health information and services in order to have an informed decision and then participate in healthcare decisions. And health literacy certainly ties in with health disparities. And this statistic is really staggering to me. An estimated 12% of all American adults have an adequate health literacy. So for all patient encounters, when we're caring for patients in the clinic, we really need to be doing our best to help maximize health literacy. When you think about health literacy, this is really where it ties into that social determinants of health. If we start on the left with this blue circle of health literacy, this is from a scientific statement from the American Heart Association about health literacy and cardiovascular disease. And you can see with these expanded circles, education, race, ethnicity, income, the community environment, first language, and proficiency with English, all then ties into access to healthcare, medication adherence, utilization of healthcare, as well as outcomes. So how can we take some initial concrete steps to make sure that we are maximizing the health literacy in our encounters with patients? First and foremost is to listen, particularly to listen to that story, to that concern that the patient is sharing with us. Using non-medical language, encouraging questions, employing the teach back method, where we're asking patients to kind of refer back and tell us what their understanding is, and then to use graphics or models when we can. And there'll be some additional references for health literacy resources at the end of this talk. And now to talk about strategies for prevention in the clinic, really focusing on PAD, or peripheral artery disease health disparities, we'll be talking about 5 aspects. Really, prevention and treatment of cardiovascular risk factors, early diagnosis of symptomatic disease, guideline-directed care, having an individualized treatment plan to help improve their functional ability, and then lastly, a coordinated care plan to help prevent complications of PAD. So if we look at number 1, prevention or treating cardiovascular risk factors with regards to PAD health disparities. I know that the other talks are going to be focusing on prevalence, but I wanted just to highlight these 3 aspects because it really ties into the prevention and treatment of cardiovascular risk factors for our patients with PAD. So Black Americans are less likely to be treated for most PAD risk factor conditions, and we'll look at those further in a moment. Hispanic Americans have higher rates of diabetes, but seem to have less PAD than non-Hispanic whites. And Native Americans have higher rates of PAD than non-Hispanic whites. So if we look at these cardiovascular risk factors that particularly impact our patients with PAD, hypertension, diabetes, tobacco use, chronic kidney disease, obesity, and dyslipidemia, you'll see that this socioeconomic disadvantaged adults are under oftentimes a higher chronic stress, and that can really impact really all of these elements that influence their risk of PAD and cardiovascular events. And so when we look at hypertension, there are high rates of hypertension in both Black and Hispanic Americans, and importantly, it is often undertreated. And this is a real opportunity not to just brush by an elevated blood pressure, but to really focus on guideline-directed treatment of hypertension. Diabetes. We know that there is a much higher incidence in Black Americans and Hispanic Americans compared to non-Hispanic whites. Again, a very important opportunity to focus on the health disparities of diabetes and how it influences PAD. We need to be identifying diabetes and treating it aggressively in patients who have this higher incidence. For tobacco use, there's been shown to be a greater use of tobacco in Black Americans compared to non-Hispanic whites, and a lower successful rate of stopping smoking for Black Americans at 33% versus 54% for non-Hispanic whites. And this was over a 25-year period. And this, I think, ties in potentially to that, the impact of chronic high stress, because interestingly enough, in this study, Black Americans were more likely to attempt stopping smoking. And so it speaks to needing to talk with our patients about strategies for stopping smoking, both from different counseling options as well as from pharmacotherapy and nicotine replacements, but making sure that that's an important part of our encounters of that visit with our patients who have cardiovascular risk factors, and certainly if they have PAD. For chronic kidney disease, we know there's a very important tie-in. Patients with chronic kidney disease and PAD have a higher rate of cardiovascular outcomes. And there are higher rates of end-stage renal disease in Black Americans. So again, a particularly higher risk population for adverse outcomes when you're layering PAD and chronic kidney disease. And obesity is often related to metabolic syndrome, and this, I think, ties into that chronic stress. You know, if somebody is living in an area where there's food desert and they don't have adequate, easy access to the types of foods that are going to help with a heart-healthy diet, then that can certainly influence obesity, and then just the chronic stress that makes weight loss so challenging. For dyslipidemia, it's important to keep in mind that Black and Hispanic Americans were less likely to be treated with statins for their LDL cholesterol and less likely to have their LDL cholesterol at goal. So this is a very actionable focus point to make sure that if we have a patient with PAD, that we are ensuring that they're on appropriate lipid-lowering therapies. So if number two, if we're focusing on prevention, we're looking at that early diagnosis of symptomatic disease so we can hopefully help prevent advancement of that disease. And it's important to keep in mind that there is a very high prevalence of asymptomatic disease and then a more severe disease on the other end of the spectrum at the time of clinical presentation seen in Black Americans compared to non-Hispanic whites. And I think the role of implicit bias is, from my perspective, just starting to get to be more involved in the dialogue about healthcare delivery. But I think it's very important to be looking at approaches and strategies to make sure that all providers across the country, regardless of rural or urban locations, are treating all patients who have PAD or PAD risk factors appropriately, and that we're not being influenced by implicit bias. So for that early diagnosis of symptomatic disease, the reason why this can sometimes be tricky, and I'm sure that the folks listening to this presentation are aware of this, but I'll highlight it because it is so important, is because only 10% of individuals who have PAD will present with that classic intermittent claudication. You can see here in blue for that small piece of the pie. In yellow, 40% will not complain of leg pain. And in orange, half will have some sort of atypical leg symptoms. And this is important work that Alan Hirsch did back about 20 years ago at this point. So what can we do in the clinic to make sure that we are helping patients have an early diagnosis of symptomatic disease? Well, we can ask the right questions. Rather than saying, only do you have cramping pain in your calf or leg when you walk, instead ask questions aimed at understanding if there's been a change in their functional status. Are they doing less activity in their day-to-day life now than they were 6 months ago? Has there been a change in their walking ability? You know, they're parking closer to the store rather than farther away. They've stopped exercising and just doing their activities of daily living. And then also importantly, asking about exertional leg symptoms, not focusing so much on pain per se, but fatigue, heaviness, or weakness, that broader spectrum of exertional leg symptoms. And then on examination, it's important to take the socks off, and we examine the feet for the temperature, for any skin changes, for any ulcerations or wounds, for any hair loss, and then to do a pulse examination as well. So we're having that expanded questions to ask during the clinical encounter, and then doing that focused vascular examination of their feet and legs. And that early diagnosis of PAD is so key because we need to reduce cardiovascular risk, improve function and symptoms, and then prevent limb loss and limb events. So for number 3, guideline-directed care to reduce cardiovascular risk. So this is very familiar. The strategies that we're using to reduce cardiovascular risk and limb events in our patients with PAD are really part of the bread and butter of how we care for patients. But I wanted to focus on a couple of aspects. So first, in the REACH registry, there is a disparity in the use of aspirin in Americans who have PAD. 62% of Black Americans who had PAD were treated with aspirin, compared to 68% of Hispanic Americans and 72% of non-Hispanic whites. So we need to do better. We need to have more of a consistent use of aspirin for prevention of cardiovascular events in patients who are at a high cardiovascular risk. Smoking cessation. We know that patients who continue to smoke are at a higher mortality related to PAD and are at a higher amputation risk. And we need to have that discussion with patients. We need to frame the importance, that critical importance of stopping smoking in that lens of a higher mortality rate and a higher rate of amputation for our patients with PAD. We talked about the lipid reduction. We'll speak about exercise therapy in a moment, the importance of blood pressure control, and then In terms of the COMPASS trial with rivaroxaban and aspirin for patients who have a high-risk presentation with their PAD or who are at high risk of leg events or cardiovascular events, there is, with the COMPASS trial, shown a reduction in both MACE as well as limb events, albeit at a slight increased risk of bleeding. And so we'll talk about further which patients may benefit from that, but making sure that we're exploring that as a potential option for all patients that we're seeing. So number 4, a treatment plan to improve function. So this is where we're talking about exercise programs. And this is how that social determinants of health, I think, become so important when we're looking at, is somebody able to access a supervised exercise program, or does it need to be a home-based therapy? And as I talk to my patients who have PAD about their exercise programs, we're trying to set up an environment that where we can have just a very safe and candid conversation about what options can they do. If it's really not an option to be able to get to a supervised exercise location, despite working with social workers to see what voucher programs there may be, then we need to look at a home-based option. So we really need to develop that patient-centered exercise plan. Cilostazol as a vasodilator can help improve pain-free walking distance and walking time. So that certainly is an option. And then making sure that we're having coordinated follow-up appointments, that patients aren't getting lost, so that we can continue the dialogue with the treatment, their medical treatment of PAD. And then number 5, that coordinated care to prevent complications. So what are those complications? We want to prevent amputation. We want to prevent limb events. We want to prevent loss of function. And then from a larger cardiovascular perspective, we certainly want to prevent heart attack and stroke. We know that patients who are at a lower socioeconomic status and who need to use Medicaid are more likely to receive an amputation for a chronic critical limb ischemia. That's despite controlling for comorbidities. And there's separate talks that you'll hear about health disparities with regards to revascularization and some pretty staggering differences in the rates of amputation across our country. But I'll say that from the awareness side of things, there are also health disparities in the awareness of amputation. Almost 15% of non-Hispanic whites were aware that PAD could lead to amputation, less Hispanic Americans at 12%, and even fewer Black Americans at 6.2%. So again, this is part of that important dialogue to have when we're diagnosing patients with PAD and during that follow-up, that we are wanting to approach guideline-directed medical therapy, the exercise, tobacco cessation, and aiming to prevent amputation. That coordinated care to prevent complications has several factors that can help us prevent amputation. That timely referral for revascularization when indicated for lifestyle-limiting claudication despite guideline-directed medical therapy. For patients who have chronic critical limb ischemia, it's a little bit of a different category than we're talking about today, with more of chronic stable PAD symptoms, exertional PAD symptoms, but certainly making sure that we're not missing an opportunity for revascularization with chronic critical limb ischemia that then is putting a patient at a higher risk for amputation. And then similarly to how we talk about patients for heart attack or stroke, brain attack, I think it's important to talk with patients about their risk for a leg attack or an acute limb ischemic event. So having that dialogue and that education about those worrisome signs, so that way we can hopefully help prevent a patient from having that acute onset of rest pain, of loss of sensation, of weakness, of cold temperature sensation that happens at home that they don't seek care for until it's too late. So educating patients about the presentation and that importance of timely, kind of quick presentation if they were to have symptoms concerning for acute limb ischemia. So talking with them about leg attack. And then lastly, a referral to podiatry or wound care if needed to help prevent or treat lower extremity skin breakdown, particularly if patients have diabetes, as about half of diabetic foot ulcers will also have PAD, and that's really where their vascularization can help with wound healing and prevent amputation. In terms of resources to learn more and continue this work in your own practice, and this is a fantastic paper that was written for racial and ethnic disparities in PAD that I would highly recommend reading. And then in terms of health literacy and tools to expand your health literacy approach in your clinic, the Agency for Healthcare Research and Quality has an online toolkit that is a very comprehensive approach for how to take a hard look at how you're approaching health literacy in your clinic and options that you can consider to better meet the needs of our patients. So for take-home points, we really all must strive to understand how health disparities and health literacy affect our patients with PAD and those at risk for PAD, because it's really only together that we can work to improve the outcomes and eliminate disparities. So for our patients, patients I see with PAD in the clinic, I really work to try to integrate that patient-centered care, understanding the influence of social determinants of health and the health disparities that currently exist in the care and treatment of our patients, to be able to hopefully help better prevent or treat their risk factors, have early diagnosis of symptomatic disease, approach a guideline-directed care, a treatment plan to improve their functional capacity, and then a coordinated care plan to prevent complications. So thank you so much for listening, and thank you for being a partner with me in working on health disparities with PAD.